Next, in this video series, we'll turn to what treatments are recommended by the NIH for inpatients with severe or critical COVID-19. In previous talks, I've shown this slide, and just to focus on the treatment of severe or critical COVID-19 depicted on the right-hand side of this figure, we are trying to reduce the length of stay, perhaps, in terms of morbidity. We're trying to reduce organ-free days, so the reduction of the need for mechanical ventilation or the duration of mechanical ventilation or other support. And in this phase is where patients suffer from high mortality, and thus one can see studies where mortality benefit has been demonstrated. And so at this time, we know that the immune system is highly dysregulated, that there are signs of what we would call hyperinflammation with elevations of C-reactive protein, of other markers of cytokines, et cetera. And so we may dampen immunity. We also know immunothrombosis may be another mechanism, and thus anticoagulation has been postulated to help. The recommendations for inpatients differ by the disease stage. And so if one is hospitalized but does not require supplemental oxygen, the figure shown here, and this is the NIH recommendation, show that there are insufficient data to recommend either for or against the routine use of remdesivir. Now, there are studies that may show some benefit, but at this time, the number needed to treat to prevent a death may be quite high. There are some individuals, particularly immunocompromised individuals, for which one may consider this. Now, if one is hospitalized and requires supplemental oxygen, the NIH recommends one of three options. They do recommend remdesivir, perhaps without dexamethasone. Whom might we put on that? Well, these might be patients with low markers of hyperinflammation, a very unelevated CRP, who are on very low levels of oxygen, who would be expected to improve after a few days of antiviral therapy. Most patients at our hospital will be receiving both dexamethasone plus remdesivir in this stage. And then for some patients, one might use dexamethasone alone, particularly if there's a contraindication to remdesivir. Now, the data beyond that stage, if patients are requiring oxygen delivery through a high flow device or non-invasive ventilation, the data for remdesivir are far less robust, and thus you can see the emphasis on using dexamethasone. Now, for patients who are recently hospitalized or rapidly increasing oxygen needs, the NIH recommends tocilizumab to one of the two options shown above it. On May 27th, just showing you how quickly these figures need to be updated, the panel also endorsed baricitinib as an option for the subgroup. Now, for patients, once they are mechanically ventilated or an ECMO, it's really mostly dexamethasone, with a very small subgroup of individuals who may have immediately gone to the ICU very quickly to perhaps add tocilizumab. What is the basis for remdesivir? This is an intravenous prodrug of a polymerase inhibitor, and thus is one of the few antiviral strategies that we even consider in hospitalized patients. It reduced viral levels in the lungs of macaques, but the proof of principle trial was the ACT-1 study, which was well conducted, was double-blind, placebo-controlled, everything you're looking for in a trial, with over 1,000 patients. And their main finding was that the recovery or the time was much shorter if one received remdesivir versus placebo, up to 4 days shorter for hospitalized patients. The mortality at 14 days was lower in patients who were on remdesivir versus placebo. So the benefit was really clearest in those who are on oxygen, supplemental oxygen, but who are not intubated. Now, there is a counterargument to remdesivir, which is the Solidarity open label randomized trial. So this trial showed no mortality benefit to remdesivir, and it's a question to reconcile these results, whether this pragmatic design would have detected the effect seen in ACT-1. Now for dexamethasone, the recovery trial showed benefit. And while this was reviewed in previous segments of this talk, one sees that the mortality benefit is much greater if patients are ventilated or on ECMO. Now, dexamethasone at 6 milligrams is a corticosteroid that was also used in sepsis, in ARDS, other severe illnesses that are triggered by infection. And so this therapy was adopted at this dosing. But we have patients who are quite inflamed and who may benefit from what I would call augmented immunomodulation. And so really there's so many agents that are being tested in this setting, but the two that we have the most evidence of benefit are baricitinib and tocilizumab. And baricitinib is a Janus kinase inhibitor. It's orally administered. It may also have antiviral properties shown in vitro, although not in primate studies. Anyways, when administered to patients at a particular sweet spot, namely patients who are rapidly progressing and who are hyperinflamed before they're mechanically ventilated, it was shown to have some mortality benefit, shown here in this slide. And this study includes over 1,500 hospitalized patients. Now, tocilizumab is an IL-6 receptor blockade. It is administered IV in this setting and was shown to have mortality benefit in recovery, shown here in this Kaplan-Meier curve, where you can see the tocilizumab group in red had a lower mortality, as well as another study called REMAP-CAP. Now, again, the subgroup analyses of these studies, and this is a theme throughout COVID-19. So for the baricitinib trial, COVE barrier, one sees the overall hazard ratio for all-cause mortality. But the evidence is really best for patients who are in what we would call ordinal scale 6, and the schema is shown in the right hand. These are patients who are on higher flow oxygen or who are on non-invasive ventilation. Now, for the other groups who are hospitalized, you can see there are, it does side towards favoring baricitinib, but the confidence intervals do cross 1, and thus there's sort of less evidence to support use in those groups. Moreover, you might be treating a lot of individuals who we know already recover to achieve a benefit. And so similarly in the recovery tocilizumab trial, one sees for no ventilator support versus non-invasive ventilation versus invasive ventilation, that it is indeed trending towards the correct side, but that the benefit was largely seen in patients on corticosteroids. And so this helps reconcile with previous studies of tocilizumab, which were smaller than recovery for one, and so less likely to show benefit and may have been underpowered, but also importantly were conducted often before corticosteroids became the standard of care. Anticoagulation for COVID-19, as of now, is yet unproven and is thus not part of our standard of care, although is widely used. Immunothrombosis is a mechanism that is well documented, with D-dimer elevations very common in hospitalized patients, and with micro and macro thrombi seen clinically and in autopsy series. Now, the prophylaxis against deep venous thrombosis is recommended, but what we have seen so far is that intermediate dose heparin did not show benefit, that therapeutic heparin may show benefit for those on low flow oxygen, but not critically ill patients, and we're awaiting more detailed data at this time. Just recently, in recent weeks, there are trials of aspirin shown in the right panel, as well as rivaroxaban for hospitalized patients, which showed no benefit. So at this time, the treatment is based on the pathogenesis of infection and the stage of illness, with remdesivir applied to patients on conventional oxygen, with usual just 5 days or until discharge, and immunomodulation with dexamethasone has become standard of care. Tocilizumab or baricitinib for rapidly progressing patients with signs of inflammation, especially if they are on high flow oxygen. And generally, these trials enroll patients early in their hospitalization and not the late progressors. One must caution that immunocompromised patients were not included in these trials in the large part, and so one should proceed with caution, as these patients may actually want their immune system to help clear the virus. Anticoagulation at this time we're awaiting more data, but is limited to prophylaxis strategies, and of course, the best supportive care. Thank you for attending this video series on the treatment of COVID-19.